minimal invasive surgery and bariatric consultant, Royal Hospital, Muscat. And he's also residency general surgery. He had done his residency general surgery in Miguel, Canada, and fellowship in bariatric in Miguel. Go ahead, Dr. Mohammed.
Assalamu alaikum wa rahmatullah. My talk today is about chronic pain post inguinal hernia repair. Thank you, Hussam, for the invitation. Inguinodinology is not yet a specialty, nor do specific inguinodinologists do exist, and those patients are difficult to deal with, and they are in trouble because there is nowhere to go to, and most of the surgeons are not happy to deal with those patients. So every surgeon has fixed a hernia with annual repair of 20 million worldwide, with 800,000 in US by itself. The lifetime risk, as we know, more in men compared to women. We are doing a good job in the era of MASH with the recurrence rate down to 2%, but there are a group of patients which we need to improve, and it's mainly those patients who are complaining of pain after the surgery. So as a definition, inguinodynia is a technical term for groin pain, or the pain, and it's the pain or discomfort which lasts more than 3 months. It can be primarily, which is not related to the prior surgery, like from sport, from strain, or secondary, which was attributed to a procedure like inguinal hernia or hip surgery by ortho. Why it happened? It's mainly because the inguinal area is not so friendly, and it's a lot of nerves pass through. The main nerves which we always talk about, iliohypogastric and ilioinguinal, with both come from the same origin and pass through the muscular part, with the iliohypogastric close to the external ring and ilioinguinal with the cord structure. We have the genitofemoral with both branches, the genital branch and femoral branch, and we have the lateral femorocutaneous nerve. This is the view we get it when we do open hernia surgery, with the 3 nerves very obvious there. The scope of the problem is difficult to estimate, with the true incident difficult to determine. This study, it was a prospective study of open repair on 419 patients. At 1 year follow-up, there was 19 of them were complaining of some pain, and 6 of them moderate severe pain on visual analog score. And the predictor was more in the patient with a recurrent hernia, and pain 1 week post-op is a predictor to have chronic pain after that. This is a Scottish population-based study on more than 4,000 patients. They sent a survey 3 months after the surgery, and they found that 43% of them will have some pain, and 3% moderate to severe pain, more in female and young age. Then they sent another survey 2.5 years after, and they found 1/3 of the patient resolved, 1/3 improved, and 1/3 of them continued to have severe pain. And when they assessed the quality of life, it was affected in those patients. This is a 5 years follow-up to assess the pain and numbness after laparoscopic and open hernia surgery on 750 patients. And although initially at 1 year there is less pain in the laparoscopic group to the open, at 5 years that difference is not that much between the two groups. This is TEP versus open randomized comparison between two. The first graph on the left showed any type of pain, and there is less pain in TEP compared to the open. This is mild pain, and this is the patient with severe pain. Then they follow those patients with severe pain at 9 years. They sent us a questionnaire to them after 2 reminders. There was 121 out of 135 response, which was a good response. And the majority of them, their pain resolved. But when they assess the physical activity, TEP patient has fewer complaints to the open. This came out of the famous VA trial, which is comparing laparoscopic versus open in 1,983 patients, and the risk of long-term pain was 8%. And the majority of 1/3 of them required some kind of intervention. It was less in elderly and patients with the highest physical activity as a baseline. So what's the etiology? It can be neuropathic pain, which is the pain with the distribution of the offended nerve, and it can be stabbing or burning, can be nociceptive with this, as somatic or visceral, which go with the meshing growth in the spermatic cord structures. We know that fast and accurate surgery is associated with good post-op outcome, and this is true, including the post-op pain. However, it's difficult to determine the precise maneuver that affect the outcome. This is true for inguinal hernia because we have different technique, and the results from those different technique is not easy to assess. We know also from surgery that or quality of life type of surgery, that successful surgery need proper patient selection, and it's not only the selection, but selection for the anesthesia, the approach, the identification of the nerve and what to do with them, type of mesh, choice of fixation, and administration of post-op pain medications. So if we find the nerve, what to do with it, preserve or excise? This is a result of randomized trial to ilioinguinal nerve preservation versus excision on 121 patient, and with follow-up of 1 year. And the chronic pain was more in the nerve preservation compared to the excision group. This is another one, open hernia, excision versus preservation of the ilioinguinal on 813 patients. And there was no significant difference between the two, but the loss of touch sensation and loss of pain sensation was more in the excision group. This was a nice one, like patients who have primarily bilateral inguinal hernia, they put one heavy mesh on one side and lightweight on the other side, and were assessed by another surgeon who doesn't know which side is the heavy and lightweight mesh. And the assessment, there was no difference between the two on VAS at 12 months. But the patient who had heavyweight mesh, they were feeling foreign body sensation more than the other group. What about fixation? The options we have either no fixation, tax, or fibrin sealant. We tend, or we feel, and it's just a feeling, not proven, that fixing the mesh will decrease the recurrence and rolling up the mesh, and no fixation will decrease the pain and decrease the cost. There are a lot of studies which look into this with different outcome. We see the chronic pain is different from a study to another. There is less in one study, and it goes up to 13% in another study. This is a stable versus not stable TAP prospective randomized trial on 502 patients. So to fix and the other group no fixation, with median of 16-month follow-up, and there was no difference between the two groups. This is TAP on 170 patients. It's the fixation versus no fixation with follow-up of 36 months. And on the follow-up, there was no difference between the two groups. It's just the cost was more in the fixation group. This is another TAP on 173 patients, tax versus fibrin sealant with follow-up of 23 months. There was high chronic pain on those patients who have tax. This is a systematic review, and the chronic pain was more in the patient who has tax compared to the sealant. What about the self-gripping mesh versus the fixation? On the follow-up on this study on 270 patients, TAP patient, there was no difference at 1 year. When we see those patients, we assess them, we assess their pain, we see if there is recurrence, and we do nerve mapping, which is very common nowadays among the hernia surgeon to do it, which need another talk to talk about. But what about treatment? We usually start if the patients come with this complaint, we start with as first line treatment as many other pain-related problems with opioids, NSAIDs, which can help with to reduce the inflammation around the nerve, acetaminophen. And then if this failed, we go to the second line treatment, which mainly work on the nerves themselves. We use medication to work on as calcium channel blocker, sodium blockers, Lyrica, tricyclic antidepressant. Then we go to the nerve block by going to specific nerve, ilioinguinal, iliohypogastric, genitofemoral, lateral femoral cutaneous, and it can be diagnosis, and at the same time it can be therapeutic. So it helped to get the diagnosis, and it also helped to treat those patients. We can use steroid, and steroid itself can make some atrophy around on the tissue and can lessen the entrapment of the nerve if it was entrapped around the muscle or around the mesh. We use radiofrequency, cryoablation, and chemoneurolysis using phenol or alcohol. What about surgery, which is the last option? It helps to, if there is recurrence, to help to deal with that. If there is an issue with the mesh and need to be removed, we can do a triple or selective neurectomy. So patients who have recurrence and they come with the pain, we have to deal also with the pain, not just with the recurrence, because fixing the recurrence may not resolve the pain. So the approach is after an anterior repair for those patients, the way to approach is we can do anterior correction, but for the nerve itself, we can go more proximal when we approach it anteriorly, or we can go to the pre-peritoneal plane. When we have the recurrence after laparoscopic or pre-peritoneal, when we access the pre-peritoneal plane, we can do anterior correction for the hernia, but for the nerves themselves, we have to go proximal to the site of where we did the surgery. If there is no recurrence and they come with just the pain after an anterior repair, we can approach it anteriorly or in the pre-peritoneal plane. And after pre-peritoneal repair, we have to go in the pre-peritoneal plane, proximal to the site of the surgery. Neurectomy, we can be selective on the nerves. We can do triple neurectomy, which involving resecting segment of ilioinguinal or genital branch of genitofemoral, iliohypogastric, proximal to the original surgical field. And we can, there is also extended neurectomy, includes segmental resection of the main genitofemoral trunk in the retroperitoneum, or go to the muscular part of iliohypogastric. There is variation between surgeons which to go to selective or triple, and those who push for triple are mainly because the innervation between the three nerves usually overlap, and those nerves usually have peripheral communication, and it's not easy to specify which nerve will give you a specific finding on your nerve mapping. On the other hand, is also they came from the same origin, usually the T12 and L1. And usually, frequently, there is more than one nerve involved with post-hernia neuropathic pain complex syndrome. Different study with either selective or triple neurectomy, the approach was mainly open with different follow-up. The majority of the patient will have pain relief, except one study which show worsening, but almost all the studies show improvement in the pain. This is from Amit on 415 patients. He did the surgery after failure of medical treatment. His patients were mixed between tissue repair, open mesh, and lab. And after triple neurectomy with follow-up of 6 months, 85% have complete resolution of the pain. And when he did sub-analysis on 160 patients who had extended neurectomy focusing on intramuscular segment of iliohypogastric, there was 95% complete resolution of the symptoms. This is from David Chen from US on 20 patients whom he did lab retroperitoneal triple neurectomy with follow-up 22 weeks. All patients had their pain improved. So each center has its own way on how to deal with this pain, and it's based mainly on the experience of the surgeon, but there was no algorithm on how to deal with them, which is recognized worldwide. Till the American College of Surgeons meeting in 2012, was consensus on chronic pain New York. This algorithm was not intended to be a rigid guidelines, but it helped to guide the surgeon on how to deal with those patients. So if it is less than 3 months, they go with analgesic, but more than 3 to 6 months, then they assess if there is recurrence. And if there is no recurrence clinically, they have to make sure with ultrasound or with MRI that there is no recurrence before they proceed. Even if there is recurrence and there is stroma, they always involve the pain service before they plan the surgery after. So as a conclusion, chronic pain is more common than recurrence, maybe lower in laparoscopic hernia surgery. It often resolves with conservative measure. And although there is no substantial evidence that the inguinal nerves should be identified to preserve them or to cut them purposely, there is a consensus that inguinal hernia surgery should be performed with nerve awareness. Following complete evaluation of the patient and attempt a non-surgical treatment, surgery may be considered. Various treatment algorithms exist with promising results. Thank you.